Hello, hello, hello. Welcome back to another episode of the Hello Can podcast. My name is Kevin. I'm your host for today and always, actually. Okay, hope everyone's doing well. I think for everyone who is listening to this from or within Malaysia, you're in a lockdown FMCO as we're going through right now. Please do stay at home because we have been hitting a peak of close to 10,000 infected cases daily, positive cases. So I know the highest that we've gone so far is 9,000 cases in one day. Please do stay home and try not to go around as much as you can. All right. In light of all of the news that has been coming out with all of these positive cases, right? There has also been a good positive news on the other end, which is the AZAC vaccines, right? So I do see that over the span of the past 3 months, there have been more and more slots, open slots for people to sign up for and to get vaccinated with the Astrazeneca AZAC vaccine, right? And I'm very happy to also see that there's a very good response from a lot of people, especially from the youngsters these days. They're looking directly to just getting vaccinated, and that will hopefully take a lot of the load or pressure and stress off from themselves, their employers, and their friends and family. Right. So it's much encouraged to go and vaccinate yourself. Please do so. But on the other hand, they have also been asking, I mean, everyone asks around, right? Your friends will definitely bring up the question, hey, have you signed up for the vaccine yet? And when are you going to get vaccinated? And when I hear that question, my answer is no, I actually did not. I did not even sign up for any of the AZAC vaccines that have came up so far, right? Whether it's the first round or the second round, which is like a week back, right? I've never signed up. I never even attempt to sign up because I have my reasons, and let me just share with you. Number one, this is not my first time researching on this AZAC vaccine, right? And what it has, what are the symptoms and what it has caused before. Previously, it is known that people who have been vaccinated via the AZAC vaccine have, some of them have cases of blood clots, right? About 70 females of 70 patients, and of this 70, 14 of them died, right, which is a rather significant number. That is easily what 10%, slightly above 15% of people that got blood clots and died. And I did some more research, but at that point of time I decided, hey, if AZAC vaccine is not it's not my preferred choice, maybe let's just wait it out, right? And then with the second vaccine slots coming up, I just did a second round of research, and this time round it's very different because when I look deeper into the research, you can see actually AZAC is banned in many European countries and even in America and Canada, right? It could be banned or it could be just restricted to usage for the elderly, right? And the reason why they're saying that, some of the countries are saying that, is because the elderly have a lower, response, or a slower response to such medication, so they will receive lower side effects, right? It's not as severe as compared to youngsters. If you have friends who have taken the AZA vaccines, I'm sure you would have heard of a few cases of them being severely with muscle sores, with fever, pain, and something like that, and that puts them out at least for one day without work, right? That means that they cannot function properly for a day or two. So with this known symptoms that is impacting the young, right? Countries like Sweden, France, Italy, Germany, Netherlands, they're all trying to ban or restrict the usage of these AZAC vaccines. Personally, I don't think it's okay to get AZAC vaccines if you know you have a day or two to lose, right? I mean, if you do fall ill, but if not, then maybe you should reconsider it. And the second main reason, I think this is the more important reason, is AZAC vaccines. How critical is it for you to get it now, right? Personally, for myself, I'm very thankful and grateful that I have a job that I can work from home, right? I don't need to meet people. I don't need to physically see people or have a long-term interaction with them. This has happened for the past year, right? I don't see people, and if I don't see people, I'm safe at home. I don't have the urgency to get vaccinated. I think there are a lot of people, frontliners, people who are working in the service industry, people who are serving you as waiters behind the counters of KFC, McDonald's, and stuff like that. They need it before me, right? We should give the chance of them to get vaccinated first, because by protecting them, they'll be protecting us whenever we go and get food. So please keep that in mind. If you're someone that usually works from home, you don't travel, you don't meet people that often, please leave the slots to people who need it more. Okay, I think everyone should play their role. Okay, and along with the research I've been doing recently, I just want to share on some of the details, right? How the vaccines came about, what are the types, and how everyone perceives these vaccines. Okay, so we do have I'll be discussing on 3 main types of vaccines today, and that would be number 1, Pfizer BioNTech, number 2, Moderna, and number 3, Astrazeneca. I will be mentioning briefly on some other vaccines, but my main focus will be these 3 for today. Okay, I hope you guys are ready, because this is going to be a long one. So please grab your coffee, tea, or water and come back. Just pause this podcast and come back, okay? All right, let's go. Okay, so the main thing of vaccines, why do we need it? Why are we developing vaccines? The first important question is why. Okay, if you guys, well, that's always the case, right? What is the goal of getting vaccines? Vaccines, there are 2 main points of getting vaccines. Number 1 is the safety of the safety of getting injected, the vaccine injected. The first thing is safety, which is the acceptable side effects when taking vaccine. Vaccines are supposed to help you or help us prevent further issues and not create another problem, right? For anyone who's working working as a programmer or working at any programming firms, you know that sometimes when you fix a bug, another bug arises. And that is exactly what we do not want with vaccines, right? We want vaccines to come up with the right capability to protect us, but at the side, just give us a very, very minor side effect. It shouldn't give us any kind of problems, right? Let's say we give hepatitis A injection vaccines, it shouldn't give us another problem like HIV or AIDS. Well, that's a different story, but you get what I mean, right? So that is point number 1. Point number 2 is the thing that everyone is discussing about, which is efficacy, right? And what does efficacy mean here? Efficacy can be broken down into 2 types as well. The first one is the protection against disease, which means in the event that you do get infected once more, even though you're vaccinated, you already have the right antibodies to respond to this external threat, right? So you know what to do, and your body suppresses the disease. In this case, it will be COVID, and you will get less, or you might not even have any severe symptoms. Your symptoms are likely to be mild or to moderate level, and you can easily treat it with without putting the ventilators into your lungs and stuff like that. Minimum treatment is required in this case. Now, the second part of efficacy is basically related to the infection, the chances of being infected again. Okay, so efficacy has these 2 rates. The first one is what is the likelihood that you'll be infected again, and the second thing is how likely that when you do get infected, you will get severe symptoms. And that is what the vaccine is for, to make sure that the efficacy is at a high level rate where it's good for everyone to be injected with or vaccinated with. Now, vaccines usually have a very fixed phases, right, of development. So the first stage, usually when we're talking about vaccine phases, right, for testing, is we first come up with the product, and once we have that product, the vaccine prototype, we will start off with animal testing. And we usually start off with mice, right, or rats, because they're very easy to monitor, easy to identify, and we know more about rats and how they react to certain things. So once you give these vaccines, right, to the animals, to the mice, the rats, the few things that we look out for is number 1, side effects. How does the rat react to it, and how severe will the side effects be? The second thing is efficacy, which is once it's injected, does the rat generate any antibodies, right? To see if they do have a positive or negative response to the vaccine prototype. And once we do see some kind of antibody, the next thing that they'll do is to give the animal COVID-19, or to give animal the virus, to see if the antibodies that were generated within the rat, the mice, can counter or combat the COVID virus. Okay, so once you know that the testing with the mice, the rats work, that's when we move on to the second phase. The second phase is human trial. Directly, we'll start off with a sample size of somewhere less than 100. Okay, so within 100 people, these people are specifically selected. They're basically in tip-top shape because they want to test it on healthy people. And when we're testing it in the first phase of human trial, the first thing, of course, we're still looking at is the side effects. How this affect the 100 people, right? What kind of symptoms do we see? Do they have fevers, headaches, and stuff like that? And then the second more important thing here during the first trial phase for humans is the dosage. Okay, in terms of dosage, two things you're looking out for is, number one, the upper limit, and number two, the lower limit. And what people ask, what does this upper limit mean, right? So upper limit means when someone gives you too heavy a dosage, which may cause severe side effects, which is something that put you out longer than you should be, right? So we want to identify what the upper limit is, and the lower limit is something where we say, okay, if we give too little dosage, this is insufficient to combat COVID, right? And we want to find that sweet spot between the upper and lower limit. That is the amount that we should be giving to everyone. Now, when that is said, when that is done, we move on to the phase number 3, which is the human trial, phase number 2. Okay, because remember our first phase was animal. Now, in the second phase of the human trial, phase 3 here, the sample size used here will be a medium number, which is about 100 to 1,000 people. And this time around, we'll be looking on a different scale. We're trying to match the demographic of population, right? Which means amongst this 100 to 1,000 people that we're trying to vaccinate to trial, we need people from different races, different ages, different genders, right? So we probably need an Asian, African American. We need Asians, we need males, females. We need someone from a younger age of around 20, some around maybe late 40s and stuff like that. We want to make it as close to the general demographic of the population as possible. So this will give us a better way to assess and see, okay, when we give out these vaccines, what are the side effects? What are the real things that we can actually expect? Because the people that we tested in phase number 1, they're basically healthy people, and they're specifically selected, and they may not represent the general population correctly. Okay, and then what's going to happen next is the dosage, the effectiveness of the dosage. Previously, in the previous phase number 1 for humans, we were looking at the upper limit and the lower limit. And with that sweet spot right now, we just want to confirm that that dosage right now is effective and it works for the general population of the 100 to 1,000 peoples that are within for the phase 2 human trial. And once we get through that, the next trial for humans is phase number 3. And we just increase the sample size from 1,000 to 10,000. Or it could be even more, tens of thousands, right? And with this large of group, we are also still trying to match the demographic of population. We're getting all sorts of people to participate. Do take note here that these are still healthy people. We're not involving anyone that could be in a vulnerable or fragile state. For instance, let's say a pregnant woman. I'll discuss that a bit later. So we'll get to there. Okay. In terms of this human trial phase number 3, they will be vaccinated. The people will be vaccinated and they'll be sent home, right? And what basically happens during phase number 3 is they have a control group, or what we call as the placebo group. So if you have 10,000 participants for phase number 3, these 10,000 people are then broken down into half, right? Which means 5,000 will be in the control placebo group, and the other 5,000 will be in the vaccinated group. I'll discuss a bit on this a bit later to show you why we need to break them down into 2. But just bear with me here that this is how they do it, and this gives us a more accurate idea of how this vaccine will work in real life. So once the symptoms, once human trial phase number 3 is good, this is actually phase number 4, right? And when we do have sufficient results that are positive enough and we think it's ready to move on to the next stage, we'll then try to submit for approval. I mean, when I say we, I mean the vaccine institutions. Okay. Unfortunately for COVID vaccine, everyone is how do you call it? They are applying for the emergency usage approval, which is the EUA, so that this can go through quicker and it can be it can be produced and distributed to people, to countries at a quicker rate. So those are the general 5 phases that you'll see for the vaccine phases, development of vaccine phases. Now, let me move on to the second part, which is how the vaccines are developed. I think this is also equally important because you know how the vaccines work. I mean, the phases, how they develop it, right? But what is the method, the technique that they use to develop these vaccines? And I can basically break them down into 3 types. I mean, these are the main 3 types that we have for now. There are more, but these are the main 3 ones that you should be of concern if you're from Malaysia. The first one is the Moderna and the Pfizer's. These 2 are using mRNA vaccines, which means they're using a specific solution that captures the mRNA cell, or I'm not very familiar with this, but they're using that mRNA thing to be injected into our system, into our body. And basically this mRNA is covered by a lipid membrane, right? It's basically similar, trying to simulate what we have in our bodies. And when this lipid membrane carries the mRNA into our bodies, right, it basically triggers and it teaches our cells, right, to make a protein that will trigger an immune response to combat against this COVID virus. Okay, this mRNA is basically somewhat genetically modified to do so. It's very different from what we have seen in our previous traditional vaccines. Because in our traditional vaccines, right, let's say flu vaccines, we're basically inserting a weakened or inactivated germ into our body, which means the flu virus could have been dead, right? But you're just injecting it into our body so that it produces the immunity response, and then we do generate antibodies to combat it. But for mRNA, it doesn't do that. It's basically a teaching skill where it triggers something within our cells to produce these antibodies without putting in the actual virus itself. Okay, so that is what we have for Moderna and Pfizer. Now, moving on, we have the Astrazeneca and the Johnson & Johnson vaccine. These 2 vaccines, basically they use the adenovirus concept. Okay, now what is this adenovirus? Adenovirus is basically a type of virus that is already out there, that people can face on a normal daily basis. It's not limited to only humans. Animals do get it as well, but the reaction is different, and humans that are not exposed to certain animal adenoviruses will not have existing immunities triggered. So let me just simplify that and summarize that for you. Imagine you have an envelope, right? And within this envelope, you have a mail or a message, right? And this message is basically your DNA. Instead of RNA, for this adenovirus is a DNA. And this envelope is basically transferred. This envelope is our adenovirus. It is transferred into our system to make the COVID spike protein, which will then trigger the immune response. The concept here is very similar to what we have for mRNA, which is our Moderna and Pfizer's, and it also produces the antibodies to fight COVID. The only difference here is that the adenovirus that is being used for AZAC is coming from chimpanzees, right? Because chimpanzees, we need to get the chimpanzee adenoviruses. We inject this DNA into the chimpanzee adenovirus, and then we use that to be re-injected again into humans. Humans that are exposed to this virus, right, this chimpanzee adenovirus, will then generate the antibody. But the reason why we do this is because we cannot directly inject the adenovirus into a human. We cannot inject the COVID DNA into the human adenovirus, because humans that are already exposed to adenoviruses, when we get another dosage of this adenovirus, our immune system basically recognizes it instantly and it kills it, right? Which means that any DNA that was injected through the vaccine with the human adenovirus will be killed instantly. You will not be able to receive the DNA to trigger and to produce the antibodies. So in this case, they need to use an animal and adenovirus to get the results that we want. And lastly, which is the most traditional vaccine method, is the Sinovac, which uses the inactivated virus, which is our traditional way of doing that. So Sinovac, I hope that I don't need to share more, because basically you're just injecting it and it's triggering a response based on the dead or inactivated virus of the COVID. Now, before I go into more details, let me just share with you, there's no preference between these vaccines, right? Because they each have their own method. None of them are basically, there's no substantial evidence to say that one is better than the other. And that's where I'll be discussing about this shortly. And then I'll show you what the efficacy is like for all of these types of vaccines. Okay, now we go into the phase 3 results for each of these vaccines. So we have Moderna, we have Pfizer's, and we have Astrazeneca, which is an AZ vaccine. So let's start off with Moderna. Okay, so Moderna basically had 30,000 people in their trials, right? And of these 30,000 people, it's broken into half, right? Which is half would be your placebo group and the other half would be your vaccinated group. So what they do is, if you're not familiar with the term placebo, basically it's everyone is trying to fake it out, showing you that maybe you've already been vaccinated with the vaccine, but actually you're not. Okay, so what they do is, for certain countries or for certain companies, what they do with this placebo is that instead of giving you the Moderna vaccine, they basically inject the trial humans with saline, which is basically nothing, right? There's no viruses, there's nothing inside it. And the patient basically assumes that, oh, hey, I have been vaccinated, I'll be fine, I'll be safe, right? I know it's a bit harsh, but they are the control group for a reason. And those that are actually vaccinated, they will be given the actual dosage. Now, of this 15,000 people in each group between the placebo and the vaccinated, for Moderna, the placebo group has 185 people that were infected with COVID, and of this 185, there are 30 severe cases. Okay, so that's fine. For the other group, 15,000 people, you have which are the people that are vaccinated, there has only been 11 infected cases, right? But of these 11 infected cases, there is 0 severe cases. Okay, so when we do the math, basically the efficacy rate of this is at 94% for Moderna, which is good, because chances of you getting infected after you've been vaccinated is very low, and once you're vaccinated, you're not going to have any severe case. Now, the same can be said for Pfizer, almost. Pfizer basically did their trials on 43,000 people. And of these 43,000 people, you also have your placebo and vaccinated group. The placebo group had 162 infected with 9 severe cases. But for the vaccinated group, you have 8 infected with 1 severe case, right? There's 1 severe case, unfortunately, but even with that 1 severe case, the efficacy here is labeled around 95%. So that puts Pfizer, I would say personally, it's slightly under Moderna, but because of it's tested with 10,000 less people, so we can't really give a substantial evidence to say which one is better. So let's continue. We then have the Astrazeneca, which was conducted on 9,000 people in Brazil and 3,000 people in UK. So we do see a different group here. So we still have the placebo and vaccinated groups here, but we do have two different countries impacted now. We have the Brazil and the UK, each carrying their own different COVID strains, right? And with these two variants, the efficacy that was found in Brazil was 62%, but the one in UK was around 90%. So that was a very significant difference between the two countries, but it could also be directed to the difference in variants, right? And of these two countries combined, between Brazil and UK, there's a total of 131 infected people within the vaccinated groups. And of all of these 131 people, there were 0 severe cases, which means that even if you do get reinfected or if you're infected again, you won't have anything severe. It's basically mild to moderate symptoms, right? And that's good. That's what we want. We don't want people to die. But because of this record, Astrazeneca has an efficacy of 70% in general when they're trying to average out between the two countries of Brazil and UK. So before we move on, here's the question that everyone has been raising. Is one vaccine better than the other two or the rest? Okay. And the answer is no. I mean, there's no direct answer. Moderna and Pfizer, when they did it with the efficacy rate of 95%, this was conducted in US, especially when the cases were just starting to rise up, right? Which means that it's not at its peak yet. We're only seeing about 50,000 infected a day compared to the hundreds of thousands that they had previously. Okay, so that's the difference. And Astrazeneca, which is your AZAC, came a bit later, and it tested during the peak when everyone was getting infected. You have 100,000 cases daily, and they also tested on different variants, which is what we've seen in Brazil and UK, right? So we do not know, because there's no trial done of using Pfizer or Moderna in with the other variants, because it's already been approved by the time AZAC came in, right, and started testing. So there is insufficient evidence to say that Pfizer is definitely guaranteed better than Astrazeneca, right? The only thing here is that Astrazeneca has a few problems with the blood clot, which I will discuss a bit in the generic questions, and then we'll get deeper into details about it. But now I think I should be talking a bit about the storage, or how we handle these vaccines. So unfortunately for mRNA related vaccines like Moderna and Pfizer, because of the complexity of how these vaccines are developed, they need to be stored in a very cold place, right? We're talking about -70 degrees Celsius. And they need to be stored that way to keep them so that the viruses inside, they do not go bad, or the vaccine doesn't go bad. And that's a very huge pain, because I mean, looking in your freezer, right, just 0 degrees is where you get ice. Imagine you need to drop another 70 degrees, and you're producing millions to billions which needs to be pushed out. So storage and trying to keep them cold at all times is a very big issue. But for the AZAC vaccines, because of its different method using the adenovirus, it doesn't need to be stored at such a cold temperature. It can be stored somewhere between 10 to 20 degrees. Or actually, I'm wrong. It's actually meant to be stored between 0 to 10 degrees Celsius. So there is a specific storage temperature, but it's definitely significantly higher than what we have for the mRNA vaccines. Okay. All right. Phew, I need a break here. Okay, so I hope that with all of the information that you've heard so far, that gives you a clearer idea of the different types of vaccines, how we're taking it and stuff like that. And it doesn't end there, because there are a lot of generic questions that have not been answered. Thankfully, when I was researching, I managed to find a video of an interview with someone named Jerome Kim. And Jerome Kim, Mr. Jerome here, is basically the Director General of the International Vaccine Institute, IVI. And he provides a very, I wouldn't say it's a clear forward answer, but he does help provide some answers to some of the questions that we as a general population ask. Okay, so let me just kick off with the first question. Number 1, people who have recovered from COVID, do they still need the vaccine? The long answer here is yes. People that are infected before, once they recover, they will have huge amounts of antibodies, no doubt, right? But antibodies, like all other vaccines, some of these antibodies will disappear, will go down, will drop over time. And when these antibodies drop, we need to boost them back up. We need to take booster shots, right? Like if you have hepatitis B, you do need to get booster shots if your antibodies are down. And that is no different from COVID. You may need to get booster shots from time to time. And the second thing is, whenever there are new variants, you may need to get a booster shot to ensure that you're covered for that variant as well. So the answer is yes, you still need to be vaccinated with booster shots if you have had COVID before. Okay, now question number 2, the blood clot issue with Astrazeneca and Johnson & Johnson. So like I mentioned before, there have been 79 cases of blood clots in the UK and 19 died. Okay, wow, the numbers are higher than as I'm seeing on my screen as reported. And he also mentions that this happens more often in younger women. So, but the thing is, there is no substantial evidence to show that AstraZeneca and Johnson & Johnson causes the blood clot, right? There's no correlation there. It's probably a coincidence. And the second thing is, even if you do not vaccinate yourself with AstraZeneca, COVID will give you blood clot as well. So your chances are equal between the vaccine of AZAC and getting COVID, right? So you have to outweigh the benefits and the cons for this. But he does mention one specific thing, which is that the blood clot issue won't happen with the mRNA vaccines, right? Which means that because of the difference in technology, mRNA could be safer and it probably has fewer or lighter side effects as well. So that's something to ponder and to look into. But of course, if you're still wondering between the AZAC and getting the other like Pfizer's and Moderna's, the answer here from everyone is this. With the COVID cases being so severe, it is definitely safer to get any vaccines than getting COVID, right? Which means that you control the spread, you don't get into severe symptoms when you do get COVID, stuff like that. So that is what everyone is pushing for. Get your vaccines, right? Just get your vaccines. It will definitely save you in the long run. And that's something for you to ponder, to think about it, and to see if it's beneficial for you to just take AZAC vaccines rather than waiting for the Pfizer's and the Moderna's. Okay, now let's move on to question number 3, vaccines for pregnant women. Unfortunately, there's no answer for this because during the vaccine trials, right, no pregnant woman was selected, right? And there's a very, very specific reason why this is the case. Vaccine trials are basically given to healthy people and people that are not expecting to give birth, right? And the reason why is because when we're testing the vaccines, this is still in early stages. We do not know what the side effects are. We do not know what is going to happen. And we do not want the vaccine to be the root cause of basically an abortion or your fetus dying within your body and stuff like that, right? We don't want that kind of thing to happen during our vaccine trials. And therefore, pregnant women, we just do not have any sufficient data. We do not have any facts on how this affects pregnant women. So the answer is this. If you're pregnant and you're worried about the risk of taking a vaccine, right, please seek a doctor's advice, right? They're probably the right person to give you the right advice if you're pregnant. And if you're not deemed suitable for the vaccines, please do stay safe and take care of yourself and the one inside you. Alright, and let's move on to question number 4. Do we still need masks after we are being vaccinated? So this comes off as a very interesting thing because in America, in the USA, once you've been vaccinated, you have the option of no longer wearing a mask. And the answer from Mr. Jerome here, which I fully agree, is that masks are still required because once you're vaccinated, yes, no doubt that even if you have an efficacy of 95% getting Pfizer, you may be reinfected. But when you're reinfected, you won't get any severe symptoms, which is fine. But can you still transmit COVID? The answer here is yes. You can still transmit COVID, and if the person next to you does not has not been vaccinated before, it can be a severe symptom for them, right? So the mask, we always remember, the mask is to protect others, not yourself, right? You're not protecting people from spitting, from transmitting it to you. You're protecting them by not transmitting what you have from you to them, all right? So the mask should still be kept, should still be required even though you've been vaccinated. The only question here is why USA is doing that is because knowing that there are so many conservatives, people who always think that just getting vaccinated will cause autism in your kids, and getting vaccinated means Bill Gates is inserting a chip to track you down wherever you are. And this is the only way they say, hey, if I know you might believe in conspiracies, but if you get vaccinated, you can remove your mask. That's the only way, to that extent, that they need to encourage people to get vaccinated. So I feel sad for people in the USA, but that is the case. Keep your mask on, vaccinated or not. And lastly, can you mix and match vaccines? Okay, this is the last question which I have been wondering. Mr. Jerome says no answer, right? There's no evidence for COVID. No one has really done a long-term mix and match between the vaccines. I mean the long term, right? But there have been people that have done it for a short term. And the facts come from other vaccines. When people, let's say if you have hepatitis B and you get mix and match different types of vaccines, you will still get that immunity and that antibodies. So with the previous historical experiences from the other vaccines, it should work, right? If you're going to mix and match COVID vaccines. So don't worry too much. You can still get it and you probably wouldn't notice a difference. Okay, so I hope after listening to all of this, that helps enlighten a lot of the information that you need regarding the COVID vaccines. Please do think it through. If you really do have an urgency to get vaccinated, please do so. But if you're working from home, if you don't meet or interact with people that much, if you think you'll be fine, please leave the slots for people who need it. Okay, especially the elderly. All right, wishing everyone a good day, and please take care ahead of the long weekend. Stay safe, and I'll hear. You'll hear from me soon, I hope. Take care.